Good evening, everyone, and welcome to our fourth week of our PRI Breathing Mechanics in COVID Times webinar series. I did post the handouts around noon or 1 o'clock today, and I posted a black and white version and a colored copy version, so you guys can kind of take your pick. If you want to print, I'd go with the black and white version, so it doesn't use as much ink on your printer. But if you just want to follow along online, there is a colored version available as well as the two technique handouts that we're going to discuss later on this evening at the end of our webinar. Those are also included on the webinars page of our website. Before we get started with tonight's webinar, we did have one question regarding last week's webinar that we wanted to go ahead and address. And so I'm going to go ahead and read this question here and let Ron address it here. This question is from Tom. In the last seminar, Ron drew a line picture of the thorax bell cavity with a black line for rest, inhale, a red sunken line, and inhale green, optimal expansion of the chest cavity. Could he visually demonstrate the difference on camera? Meaning, could he show us what the optimal green inhalation looks like versus the red bottom out dysfunctional inhalation? Might he be able to show us an exaggerated right and dysfunctional examples with his own bodily demonstration?
Okay. Well, good evening, everybody. Jen, thanks for putting this together. And what was the name of this guy? Tom? Tom, thanks for the question. I went ahead and redrew the diagram, Tom. I'm not an artist, but I try to kind of simulate what I was drawing. I did that freehand last week. I'll do it. Let's just conceptually talk about this for just a few minutes. Our chest wall houses these lungs, as we all know, and the chest wall itself mechanically can obstruct and restrict and compromise function. So we need to bear in mind that we have two of them. It's a hemispherical chest wall with two hemi-diaphragms that connect, and they both have central tendons, as we all know. So I always draw the central tendon a little higher on the right side than the left side because of this organ called the liver, and because of the position of the chest wall. The black, and I know I've got a lot of lines up here, but Tom, the black is just a normal resting chest wall. I didn't draw what happens to the diaphragm with it when you take a breath of air in, and you let the air out, the chest costal fibers are going to expand. The crural fibers are going to pull the back backwards, if you will. And the entire umbrella will open up universally, hopefully everywhere on both sides, to some ratio that will not twist the spine when you do so. Now, a lot of our patients that we work with, a lot of the athletes, a lot of the people we work with, they'll take a breath of air in, Tom, and when they breathe in, their spine will naturally twist because of impedance issues and co-contraction issues and resistance issues and lack of opposition issues provided by the abdominals and intercostal issues, et cetera, et cetera. That's not what this diagram is all about. This diagram is saying those individuals that have a green line, that have a nice, good chest wall that's going to expand, when that diaphragm contracts on both sides, the entire chest universally will expand. So I'm going to try to demonstrate that. So my shoulder blades are now more anchored, and I feel more grounded, and I feel more sounded, if you will. I feel a resonance more than I did when I was out. I let that air out. So when I take a breath of air in, everything on all sides of my body just expanded, Tom. So everything is expanding. My apical chest wall is expanding. My base is expanding. My lateral walls are expanding. Just consider everything expanding. And that's really cool because in that individual's probably got enough intercostal flexibility, enough ability to, enough appropriate impedance where the chest can actually dynamically expand by the contraction of the diaphragm that's producing an internal negative pressure it's actually drawing in air in ventilatory air in as that same air is pushing up on the inside walls of your chambers of your chest. And that's what that green shows. And again, it's just a schematic. The red shows individuals who are more linear, more converged, probably have weaker diaphragms. So when they contract, the diaphragm can pull some air in, but not satisfactorily. What it'll do, it'll pull the air in more from a sagittal pull. So in the back of my body, the crura will fire and my ribs will pop up and my body will narrow in, because as I pull that air in, everything, instead of expanding universally, is being pushed forward, and as my neck and my head accessorizes that pull. So you'll see things being drawn forward on people who like to move their bodies forward, move their heads forward as their bodies are actually moving back because of the sagittalism of that pull, the sagittalism direction of that plane of pull. So I hope that answered the question. So people who have a universal restricted chest wall because of lack of opposition provided to the apposition fibers, the zone of apposition fibers of the diaphragm itself, those individuals, when they take a breath of air in, Jen, they are really abless. Their abdominal muscles aren't doing a satisfactory job of maintaining enough composure to that bell-shaped chest for universal expansion. And that's really all it was. We had a week, I think it was a week, on negative pleural pressure. And negative pleural pressure is dependent upon abdominal control, abdominal opposition. Did I do okay with that, Jen? Is that kind of what they wanted to hear? Hopefully, Tom, that answered your question. If you're on, raise your hand. Is he up there somewhere? Did that? He may not be on, but okay. This week is a special week. They all are. I want to thank you for joining us. But the title of this webinar is Regulating Lung Carbon Dioxide. Carbon dioxide, Capnia, through postural end range deep breathing. In range in physical therapy terminology means you get into a position where there isn't much movement left because you're at the in range of that position. If we talk about in ranges with people who have capsular issues or joint issues, we're going to talk about in range as it relates to this chest wall, and as it relates to lung function, as it relates to breathing. So the number one concept tonight is how does carbon dioxide regulate our function, and how does carbon dioxide interfere with our physiologic and physical well-being? And so this is a discussion about regulating our lungs' ability to exchange oxygen with oxygen, and we do need carbon dioxide, and change carbon dioxide with oxygen. So we'll go through it. I think the handout will help. I like to talk about how our lung function can possibly contribute to our overall behavior, our chest mechanics, and our spinal orientation. The human body is built to naturally maintain a healthy balance of acidity and alkalinity. If our lungs or kidneys are malfunctioning, our blood pH level can become very imbalanced. Thank you, Jen. This imbalance is often seen in those with kyphoscoliosis, or curvature of the spine, where the right diaphragm is positioned at the end range of exhalation as a result of increased lateralized postural stabilization, enhanced by a very active zone of apposition, soft tissue, which would include your abdominals, comparatively to that of the left. So basically, when you see this imbalance of carbon dioxide and oxygen exchange, you're going to think about this afternoon, this evening. You've got two lungs, two hemispheres, and they both are producing oxygen, or they're both producing the ability to exchange carbon dioxide with oxygen. But they both are in different positions, and they both have different mixtures of that gas. So their ratios are going to be different because of how they are actually positioned and how they actually position themselves to help that overall lung function with respect to the ratio of the gas. So the overall lung function on this side is restricted compared to that on the left side. So this evening, I want us to think about the right lung as being the more restricted lung. It's not true, but it's fairly true across the board to some extent. I can't tell you that every single human you're going to work with is going to have a more restricted lung on the right side than the left, but there's going to be more overall impedance, more overall tension, whether it's nervous tension, neurological tension, or actual mechanical tension from muscle and soft tissue. So Jen, now would be a good time for me to show them this whiteboard. You don't have this in your manual, or excuse me, in your handout, but I'm going to leave it up here during the whole 45-minute discussion this evening, because we're going to talk a lot about respiratory acidosis and respiratory alkalosis. I don't want these two words to interfere with the discussion regarding the form that we just talked about as it relates to carbon dioxide. But again, this imbalance is often seen in those with people that have more diaphragmatic positioned, diaphragmatic positioned activity on the right side versus the left side. And when I stand on my right side, Jan, my diaphragm on my right side has more assistance from an organ underneath the central tendon and a boundary that is on the other side of the diaphragm attachment site on the ribs that include abdominals and intercostals. So our right diaphragm is more supported, more controlled, more regulated, and therefore a little bit more stable. I wrote up the words respiratory acidosis, which means, and I'm going to read this to you, and we'll leave it up, and you can write this down if you like, but you have most of this material in your handout. Respiratory acidosis is inadequate exchange between carbon dioxide from the body for oxygen from the air because of the restrictive chest wall, intercostals, or abs during inhalation. So when that happens, when we have overly restricted activity on one side, especially on the right side, which we often see, our carbon dioxide levels will increase. Our carbon dioxide levels in our body usually increase initiated by the right side before the left, because the position we're in to have this exchange occur is at a higher level than the left side. The respiratory alkalosis is a definition that says inadequate exchange between oxygen from the body for carbon dioxide from the body, which means we're producing carbon dioxide when we move and when we work, and we want to exchange it for oxygen. But when we have so much oxygen in there because of what our body is doing, our ribs are coming up and we're losing our zones of apposition. At that point, our body is producing a lot of carbon dioxide, but because of the unrestricted anterior chest wall that it elevates, our carbon dioxide levels start to go down, and our oxygen levels with respect to the carbon dioxide levels start to go up. We see this more occurring on the left side. So when you get into this alkalosis state, where I'm thinking usually that's going to probably be initiated by something that occurred that made you become alkalytic, but it was probably enhanced by the position you're in with respect to the diaphragm, the rib cage on the left side. Now I'm going to leave this up for this next 30 minutes, and we'll refer back to this because I underlined two words, restrictive and unrestrictive, which means when you start looking at chest wall mechanics, we should be considering both the mechanics and the physiology associated with those two words as it relates to respiratory pH balance. So there's a direct tie to pH balance, the respiratory pH balance, not your metabolic kidney pH balance. There is a direct tie between pH balance and the position you're in with your chest wall and the position your diaphragms are in when they take a breath of air in. Okay, so here's a picture on the right side that shows a good zone of apposition, a diaphragm that's up into the chest wall. It's got a nice bell-shaped curve to it, and it's ready for one thing, inhalation. And when it inhales on that right side, as we talked about earlier this evening, things will expand. Now, this is not an unfortunate picture. You will see this kind of activity on the left side. You'll see the top of the central tendon a little lower than that on the right side. And if there was going to be a place for this alkalosis to begin with, it would be on this side. This is a side where your CO2 levels probably by themselves, that chamber by itself, that set of lobes on that lung probably is lacking more carbon dioxide than the other side that has a good resonance, good ability to expand and exchange carbon dioxide for oxygen. So keep again in mind, we're going to talk about these two chambers as it relates to pH imbalance. And I'm going to leave this on the board, but I want you to physically see the representation of pH respiratory imbalance by looking at that picture. That is not a negative set of slides. That's a pretty optimal set of slides when it comes to how we usually put ourselves in a position for an effective enhancement of good respiratory exchange. Then if you draw it out, Jen, thanks for putting these two pictures in, Jen. We've got this optimal zone of apposition on the right side, which reflects what I just showed you in the previous slide. And then you got this suboptimal position, the zone of apposition on the left side. Now, you can get optimal positioning of the left side by getting the ribs to pull down that rib cage, but maybe your exchange of gas ratio and your physiology is saying to your physical components of your brain, I really don't want to be symmetrical on both sides. I like the balance that I have in my system. I'm balancing my pH level out by a little bit of less carbon dioxide on one side, a little bit more carbon dioxide on the other side, than actually balancing that system out with the normal physiology of balance between the pHs, and the ranges they're in, as a typical human would do. So there's another component we need to consider here. pH imbalance is reflective of whether or not you can really get over to the left side and stand on the left side and get your mass over to the left side. If not, there's a certain pattern of pH imbalance acquisition that we're going to find out with this discussion this evening that leads into this lack of carbon dioxide called respiratory alkalosis, or hypocapnia, which we're going to get into. This lung imbalance between the two sides of the body impairs exercise tolerance and increases your carbon dioxide retention, or hypercapnia, induced by limited chest wall expansion during inhalation, usually again initiated on the right side. If our right side, Jen, doesn't have the ability to expand over time, that side will start to, limit your ability to expand, and that side will start to lend itself to a state of hypercapnia. Our right lung lobes are more often responsible for initiating physiologic and physical behavior patterns associated with hypercapnia. Hypercapnia, or when we look at hypercapnia, we're looking at things called acidotic or acidosis, more so than our left lung lobes. The left lung tolerates more overall lung expansion because the ribs flare out easily and air moves out laterally and anteriorly more easily, and therefore more oxygen, alveolar sac ventilation than the right lung occurs because of the diaphragm's difference in size. The left diaphragm is smaller, and overall the lung size on the left is as well smaller. The diaphragm function and size induces more of a hypocapnia state, an alkalytic state, or hypocarbia state, not enough carbon dioxide state on the left because of this overall hyperventilatory function and accompanying lung size on the left side. We'll go over the symptomology related to these two examples here in a minute, but that's a really important slide. The function of the diaphragm when it's in this imbalanced, over-imbalanced state, if you will. Poor left zone of apposition is often seen in this physiologic imbalanced divarication between the two sets of lungs. So you got this opposition that's often seen physiologically imbalanced between the two diaphragms when the left rib cage is higher and elevated and the right rib cage is lower and more converging towards the center. So here's an example of that. You can see the individuals that the slides that Jen picked. You can see the individual on your left side. You can see the rib flare on the left side, the hypocapnia, the person that's going to be probably dealing with low carbon dioxide. I'll tell you the pattern of this functional development here in a minute. But if you look at that individual's right side, it's more secure. The diaphragm is more stable. And on the left side, it's more insecure. And the diaphragm is less stable. When we take a deep breath in through our nose, hopefully the air will move into each set of lobes equally, hopefully. That rarely happens, but hopefully it does. However, because of how we breathe and the way we breathe, we may not be able to balance oxygen and carbon dioxide levels in the body, nor balance these levels through asymmetrical symmetry functions provided by our biased diaphragms. So our biased diaphragms keeps our symmetry of our body asymmetrical inside. And that's how we sometimes regulate where our acidity is or our alkalinity is through the way we position ourselves. We don't do it intentionally, it's physiologically what we do. So you can see this individual on the left side of your screen. This is an antecedent left hypocapnia posture. That means prior to his hypocapnia posture, prior to his respiratory alkalosis, he was in that position. His right rib cage is tight, his left rib cage is a little tight, and he's struggling to get air in. As he grows up, these individuals become very hypocapnic in general, and his left's still more hypocapnic than the right. But the gentleman to your right on your screen is definitely carbon dioxide challenged. The carbon dioxide in that individual is limited because of the way his chest wall is operating and the way the lungs cannot function. More often than not, someone who is spending most of their upright day with weight bearing or with weight being placed more on their right foot will eventually follow the body's path of least resistance and could fall or rely on their joint capsular end range and soft tissue associated with that end range for respiration patterned from a state of postural imbalance. So our physiology is directly tied to our postural end range ease. The areas that we go in for natural postural support, passive support, if you will, has a direct influence on our pH balance and how we feel and on our overall behavior that corresponds with that pH imbalance. In essence, many of us develop a compensatory pattern of respiration that results in hyperventilation. Hypocapnia is hyperventilation. This slide right here, or this part of the whiteboard, which is reinforced by our left lung tendencies. So when I look at left lungs, I think of hypocapnia. When I look at right lungs, I think of hypercapnia. This usually occurs after moments associated with hypercapnia, which is reinforced by our right lung tendencies. Here's what I'm trying to get across. Before you become hypocapnic, before you really are not developing enough carbon dioxide, you go into this state where you have too much carbon dioxide. And when you have too much carbon dioxide, you're going to breathe. You're going to try to get that air. You're going to try to get that oxygen. And as you try to get that oxygen, you're going to pull in muscles of the anterior neck wall. And once you start pulling those muscles of the anterior neck wall, that'll complement the muscles in the back of your posterior body. Those posterior back muscles, along with the anterior neck muscles, start to assist you to getting more oxygen because that's what you want. Next thing you know, you're hyperventilating. And next thing you know, you're not producing enough carbon dioxide. A large percent of those individuals that we work with as movement specialists are dealing with patients now in universal hypocapnic states of physiology. And their metabolic issues of alkalosis is going to complement that over time. So the process really starts off with with this thing called hypercapnia on the right side, and usually leads into hypocapnia before it's all said and done, because our bodies govern themselves. We need more oxygen. We try to get oxygen. As once we get the oxygen going, we start breathing in oxygen, but we forget how to what? Exhale. And once we forget how to exhale, we stay in that CO2 deprived state called hypocapnia. The thing that I think is most important right now is to just take a minute and pause. We don't work with patients who don't know how to breathe. We work with patients who do not know how to produce carbon dioxide. Carbon dioxide is something we absolutely have to have, as you're going to find here in a few minutes. We have people coming in who are short of breath, and they can breathe with shallow, quick little bursts, but they can never really exchange because that oxygen never gets into the lower parts of their lobe for perfusion. So they're starving for oxygen, and as they starve for oxygen, they continually assist themselves by extending their bodies and pulling in that air. And as they're doing that, their carbon dioxide ratio to oxygen ratio goes completely down, and now they become alkalytic. These are individuals that really now have problems with behavior that have to be first managed by their pH imbalance, which we'll talk about with these two techniques that we're going to look at this evening. Antecedent, that means behavior before something occurs. Antecedent behavior, increased hyperventilation, hypocapnia, is often hypoventilation, hypercapnia, which is what I just talked about. Jen put this together. She said, in other words, shallow breathing usually precedes hyperventilation. Underline it. Shallow, quick little breaths precede hyperventilatory activity. So the goal is to get us to breathe correctly so that we can use our body to exchange that CO2 with the O2. But when our body can't do that because our body is in a position of threat and we need more oxygen and we are trying to get it and we can't get the oxygen because we can't get it out and we can't get more carbon dioxide because of that, we're kind of trapped at that point behaviorally in terms of what we do as a human with our sympathetic activity. Hypercapnia, especially when it's created initially by the right side of your body, that then can get to your system completely, followed by hypocapnia on the left side of the body, then get to your system completely over time, caused by hypoventilation in the beginning, increased CO2 in the beginning, increased respiratory acidosis in the beginning, shallow breathing in the beginning, diminished consciousness or confusion. People that come in there are very confused and can't remember what you told them before they even walk out the door. Your disorientation, your disoriented people, those people that have not slept in days, those people that are fatigued, headaches are all symptoms of hypercapnia. The number one symptom of hypercapnia, shortness of breath. They can't get the air in. Their chest wall won't let it happen. Kyphoscoliosis, curvature of the spine that will not allow that right chest wall and that pleura to expand. That's called poor pleural compliance. We've talked about that in previous webinar events. Hypercapnia ensues when impairment in ventilation occurs and the removal of carbon dioxide by the respiratory system is less than the production of carbon dioxide in the velar walls. Circle that. Hypercapnia, acidosis, ensues when impairment in the ventilation occurs, when an impairment in ventilation occurs, when a chest wall cannot open up because you didn't have the ability to shift your mass over to the other side so it could open up, or you didn't have the ability to get your arms and your legs moving so the chest wall could unwind, et cetera, et cetera, et cetera. Physics precedes physiology. Physiology drives physical impairment of the chest wall. That's the take-home message this evening. If anybody thinks that they're going to do activities where there is not going to be some physiological manifestation from that activity, That slide puts it to rest. Your physiology dictates your behavior. Your physiology dictates your management style, and your physiology dictates on your fatigue level. So I think that's really an important thing to remember. Conditions that contribute to respiratory acidosis are asthma, emphysema, and severe pneumonia. I know I've worked with many of these patients who have never had asthma, have never had emphysema, and do not have severe pneumonia. But you would swear they had all three. And it's because the mechanics that preceded that activity stimulated that activity so that the simulation of those events looked like they were acidotic because of those events, when in reality, their issues were related to what they could not do with their chest wall, beginning usually on the right side. Causes could include narcotic use, sleep medication, nervous system disorders, in addition to that. So it's a complex situation. If you have patients that have the latter, then on top of this mechanical inability, coupled with maybe they do have asthma, you got to do everything in your power to make sure that they're getting that air out of their body. Otherwise, they're going to try to get more air in, and that leads into lack of carbon dioxide. Once you get into this hypocarbia or this hypocapnia, carbia state, it's very difficult for people to actually get out of it. You have to stop them for a minute. We're going to talk about that, to put them in pause. You have to slow them way down. Hypocapnia, alkalosis, is caused by hyperventilation and anxiety. Aspirin overdose, high fevers, or even pain can produce hyperventilation. Decreased CO2, underline it. This talk is about people that you're working with that more than likely have a bigger issue with decreased carbon dioxide in their system than the aforementioned situation. These are called hypocarbia patients. Anytime you see a left rib flare and a tight right chest wall that's being worked around ground that exists only under the right side of their body, with a right sternocleidomastoid and a right scalene wall, assisting them to get air in a hyperventilatory way. As the ribs start to go up bilaterally, you know they're hypocarbia. And you know more than likely that hypocarbia started on the left side and then spread over to the right side, but it started on that left side. For all the reasons we talked about earlier: lack of opposition, lack of a zone of apposition. Increased respiratory alkalosis is now a given, and these people get dizzy. They're your POTS patients. They get really lightheaded. Their bronchioles are constricted. They can't exchange. Perfusion is difficult. Ventilation is difficult, but perfusion is even more difficult. Carbon dioxide has to be sufficiently there on board in order for your body to make oxygen before oxygen will be available from the outside environment, to actually get it, to produce it, to have it. Producing it means it goes through your airways. Carbon dioxide has to be there first. You have to have it first. You have to be able to exhale. You have to blow out a balloon. You have to get the air out. You have to move your heads forward after you get the carbon dioxide. Your heads will always go forward and lead you if you don't have carbon dioxide doing that first. I hope I said that right. Did I mess that up? I hope not. There are two ways of balancing our sets of lungs and the body's pH. And that is through the management of carbon dioxide, through the speed, underline it, of ventilation, and the stance, underline it, we ventilate with. Very important slide. I wrote this yesterday, and I think that's the slide of the day. There are only two ways of balancing pH of the body. That's through the management of carbon dioxide. There's only two ways to teach somebody how to breathe correctly. You've got to make sure they go slow, and you got to make sure that they can do it on the one leg as well as they can do it on the other. Otherwise, there is going to be a disruption in the mixture of gas ratios between carbon dioxide and oxygen. Our left lung lobes need us to be mindful of our left foot and left ground as we inhale and exhale slowly. Underline it. The pH balance of our blood depends on some percent of our 25,000 inhales and exhales a day that should be done while we are on our left leg and our left foot. Otherwise, in addition to feeling dizzy, lightheaded, and anxious, we're going to gain weight. James Nestor just put this book out, Breath, and Jen was so kind, she pre-ordered it for me. If you haven't gotten a copy, you might want to get it. He's a journalist. He did a really good job talking about breath, but this I stole from him. He wrote in his latest book, Breath, we lose weight through exhaled breath. For every 10 pounds of fat lost in our bodies, 8.5 pounds of it comes out through the lungs. Most of it is called carbon dioxide mixed with water vapor. The lungs are the weight regulating system of the body because of it. If you're in an alkalytic state, if you're in this hypocarbia state, if you do not have CO2, you are going to gain weight. It's impossible for you to burn it all off. You're not burning any of it if you can't produce some carbon dioxide. Take home message, keep your left rib cage in the right position. It will never stay in the right position if you can't pick up your right leg and balance over it while you're breathing once in a while, called left stance. Advocates of the Buteyko, Tai Chi, and Buddhist breathing, which we're going to talk about in the last few sessions of this webinar, practices will encourage us to breathe 5 to 6 times a minute to help our brain constantly monitor and maintain proper pH balance. 5 to 6 seconds to breathe in, 5 to 6 seconds to breathe out, with a pause before the next breath will give you 5 to 6 breaths a minute. That will immediately start to lower your blood pressure and lower your temperature and bring you to parasympathetic resolve. And it also will do that all through the effectiveness of carbon dioxide being not produced. Breathing less has a profound dilating effect on blood vessels and allows our lungs to soak up more of the oxygen when we slowly inhale in, after we slowly exhale out. Few words about control. You want to control carbon dioxide. And carbon dioxide is the one gas that I really haven't talked about oxygen a lot in my life, Jen, but carbon dioxide is the one gas that maintains you posturally. It's so important to understand that. Without it, you're going to be light. You're going to be full of oxygen, dead oxygen, and you're going to be kind of floating around. Carbon dioxide grounds you. It's a postural gas. An important characteristic of the human respiratory system is the ability to adjust breathing patterns to changes in both the internal milieu and the external environment. Ventilation increases and decreases in proportion to swings in carbon dioxide production and oxygen consumption caused by the changes in metabolic rates. This is that ebb and web stuff. We need to be going up and down with our carbon dioxide, just like we have nitrous oxide going up and down, and we have this nasal vestibule cycling back and forth, sympathetic, parasympathetic. This is called oscillatory alternating activity. So it's really important for you to appreciate that ventilation requires that ebb and web with carbon dioxide production. The respiratory system is also able to compensate for disturbances that affect the mechanics of breathing, such as the airway narrowing that occurs when one positions themselves in upright, anti-gravitational, end range positions where they relax and rely on both on joint capsule tegument and tissue for support, as I am right now on my left leg. An asthmatic attack can instill the same respiratory compensation. If you watch people who are really short of breath and are having asthmatic attack, they will get off their right foot and they will be moving around. They may sit, they may lay on the ground, but they're going to go to the left side because they're doing everything that they can to get to an in range for a diaphragm that's going to need as much help as it possibly can to get the air out of their system. Our breathing undergoes appropriate adjustments when the mechanical advantages of the respiratory muscles are altered by postural changes, or by movement, or by an asthmatic attack. I see people walking around that are constantly showing behavior that they're struggling to get air in, struggling to get it in because they can't get it out. This flexibility of breathing patterns largely arises from sensors, underline the word sensors, that understand the word slow-mo, movement, slow flow. Sensors that understand slow flow, distributed throughout the body that send signals to the respiratory neuronal networks in the brain. These are called chemoreceptors. They detect changes in blood oxygen levels and changes in the acidity of the blood and brain. Mechanoreceptors monitor the expansion of the lung. So when your mechanoreceptors experience that expansion, those chemoreceptors are saying, thank you for listening, thank you for helping, thank you for enabling. Mechanoreceptors monitor this expansion and the size of the airway. That's what this is all about. Airways, the size of it. The force of respiration muscle now is going to be purposeful, and it won't be so high. Things are going to move in a little easier. You're going to do things with less effort. And the extent of muscular shortening. Take away carbon dioxide, all that goes south. Things constrict, diaphragms have to work harder, more accessory muscles, floors go away, extension, sympathetic fight and flight, and blood pressure goes up. The following 2 PRI techniques that I select this evening for this webinar should enable one to take into account this detection and monitoring of lung dynamics. The first one's called the PRI wall-supported squat with balloon. Now, we're going to not read all the steps to this, Jen, but we're going to go over a few concepts, okay? Jen, how are we doing? Doing okay for time? Okay. Jen, I'm going to have you read, I'm going to take a drink of water. I want you to read the first 4 steps, if you could, for me. Just read the first 4 steps.
Okay, PRI wall supported squat with balloon. Stand with your heels 7 to 10 inches away from the wall. Place a 4 to 6 inch ball between your knees and a balloon in your left hand. Place your bottom on the wall and slide down by slightly bending your knees. Round out your back as you perform a pelvic tilt so that your low back is flat on the wall.
So positional, positional, positional. What Jen just did is put the 2 diaphragms in a neutral state. So neither one of them should really be, subjected to any higher or lower CO2 levels at this point. She just said, round your back out, get your heels on that, that telephone book or whatever you told me you're going to put them on.
Yeah, well, that's not in the steps,
But get about 7 inches away and get yourself kind of leveled out. Butt where, Jen? On the wall. Once that butt gets on the wall, this goes away. You've got now a chamber on both sides that kind of get a same playing field. Now, step 5 says shift your left hip back. Your left knee will be slightly behind your right, and you will feel your left outside hip engage. This is what's important about this step. By feeling your left outside hip or buttock engage in this shifted state, you are positioning yourself in a deep in range. They have this, right? Underline it, okay? A deep in range sense of your left abdominals to move the left ZOA or abdominal attachment site or the ribs to approximate the anterior hip. And when that occurs, you're now beginning to take this hypocapnic state and make it more mixed, a more mixed ratio state of goodness. You don't want it hypercapnic, but you're mixing it at a proper balance. Just by doing that one thing. Now, we haven't breathed yet, but you know they're going to be sneaking in a breath here. Step 6, squeeze the ball gently with your left knee and inhale through your nose. As you exhale, reach forward and across the midline of your body with your right hand. Okay, why do we think this is so important for carbon dioxide techniques? By inhaling with your left knee pushing into a ball that is placed between your knees, your center of mass will shift over to the lateral side of your left foot as you slowly fill your left lobes that are positioned in this new novel state. It's slowly happening. Count to 4, count to 5. This inhalation expands your posterior left lung surface and your lateral anterior right lung surface thereby offering more room for elongation of lung tissue in these areas during exhalation, which is coming up. In other words, you're stretching tissue out, Jen, at in ranges. So the next thing you do, exhale, you can get more zones of apposition. On which side, Jen? Left. So opposition from that diaphragm can be now held together by the previous step that brought the ab muscles tightly together, along with everything else that we mentioned on that previous step. Now you're ready for the next inhalation. But this is a big step right here. This is where you're going to maximize carbon dioxide levels. You're going to maximize oxygen levels. The ratio, the pH, this pH balance is going to balance out just by putting you in this position. And even if you breathe incorrectly, you still like to breathe too fast. You still don't know how to draw it in. You still don't understand how to anchor yourself with your butt on the wall. You still don't know how to get the floor to come up. Even if you do this all incorrectly, not worry. Don't worry. It's feed-forward activity. You're in a position that is more hypercapnia than hypocapnia minded. By reaching forward with your right hand now across your body, slow exhalation should occur. You're attempting now to balance this normal levels of respiratory carbon dioxide. That one would expect to, which we would expect to find in unpatterned sets of lungs or in a person with a more neutral hemispheric rib cage. Those people do walk around, but they're far and few in between. So keep that in mind. This is the first time that individual is going to feel like, what does it really feel like, Jen, to have a neutral set of lungs, a neutral set of pH balancing lungs? Overall bronchial dilatation resulting from this sequence of respiration in that position should decrease your respiratory alkalosis. And if that occurs, then your CO2 should be at a normal carbia level. That is a major slide again when it comes to why is this technique in this particular webinar so important. Carbia at a normal level is going to happen when that individual takes a breath of air and slowly exhales into that balloon. All right, next step. Maintain the above position. Inhale again through your nose. I'm reading it word for word. Again, this time slowly exhaling into the balloon. By inhaling again through your nose, you are simulating left nasal parasympathetic activity because of this position the head is in. It's called a right cranial position of flexion or a left cranial position of extension for those people out there that have taken the cranial cervical course. When the left foot or floor is coming to the right hand. Your blood pressure, your temperature, your anxiety all should improve, provided the nasal airways are open. If your nasal airways aren't open, this may go south on you, but you're going to do everything you can to get those things open during this process. Balancing CO2 with this technique requires one to go slow. Jen, I counted this. The word slow is written at least 4 times in this instructional set of steps. So slow is the word on this technique. And the slower you go, the more carbon dioxide you're going to make. The slower you go, the more appropriate oxygen ratio to carbon dioxide you're going to have. Carbia is so important to balance out with that oxygen. And this is the technique that'll do it. Pause 3 seconds with your tongue on the roof of your mouth to prevent airflow out of the balloon, to prevent airflow out of the balloon. By maintaining your tongue contact on the roof of your mouth, you are maintaining opposition to the left diaphragm because of that balloon. That balloon makes sure those costal fibers are right where they're supposed to be, are right in the position they're supposed to be to appropriately balance CO2 with O2 ratios. That enhances, increases your ability to maintain it by keeping that balloon in your mouth without losing the effectiveness of that new ratio of gas. I think the rest you can read. I think you get the idea on this, Jen. Is there anything on that handout that you think I should go over before I go on to the next one? This is the #1 carbon dioxide PRI technique in our institute. It was the very first one I ever did in my life when it came to putting a telephone book on a floor 7 inches away. from the wall. This technique is the very first technique in this institute that said, take a balloon in upright activity and learn how to tighten up your zone of apposition on the left as you maximize hypercapnia on the left side and hypocapnia on the right side by doing this balloon activity with an arm that's crossing over, with a leg that's being held together by a ball between it. And as you're doing this, going slowly with inhalation and exhalation. I don't believe in my years of doing PRI or teaching PRI, I had ever had the full ability to explain a technique like this, like I do this evening, because we didn't do these webinars for everybody back then or today. We're doing it for you to remind you that every one of these activities that you see in PRI has a level of pH balance, pH mixture going on. This is one example of it. Anytime you see a balloon, think carbon dioxide. A balloon is going to help you breathe better because it's going to help you get carbon dioxide. A large percent of your patients are individuals who have hyperactive backs, ribs that are popping up in the air, that are living on too much oxygen. They're hypocapnic. I just talked to a dentist today, a few minutes before I took this webinar on. And he said, aren't we all a little hypocapnic? He's a dentist. Yeah, we all are. If you like to work out and you're not good at working out in a slow-mo way, you're more likely hypocapnic. So this next technique I like because we're going to now do something with this technique that we just left, and we're going to move on to shifting your body weight by moving hands to redirect airflow with your arms involved. So we call this the PRI wall supported squat with respiratory right apical expansion. Am I doing okay with time? Okay. So Jen, I'm going to have you read the first four of the.
Technique does first or wait?
Do I have that down? Yeah. Yes, let's do that. I forgot about this. This technique allows us to produce carbon dioxide with more emphasis placed on exhalation as outlined in the previous technique. Both of these techniques are carbia techniques. They're both exhalation techniques. This would be an opportunity for you to do this. Write down the word exhalation, and then next to it, write the word carbon dioxide. Exhalation produces carbon dioxide. It does not produce oxygen. Inhalation produces oxygen. And you are, I guarantee it, are one of many people out there that are over-oxygenized with dead oxygen still hanging in your chambers. So these two techniques mixes that oxygen with carbon dioxide, with more emphasis being placed on the word exhalation on these two techniques. We're all about inhalation. Everybody wants airways. Everybody wants them. But to get the diameter of the airway open, you have to have carbon. You have to have carbon dioxide. I won't get into the bicarbonate discussion this evening. We'll talk a little bit about it later, but carbon dioxide to get you to relax. So in the previous technique, we went over all that with one caveat. We didn't talk about right trunk rotation in that last technique. We are in this technique. Right trunk rotation enhances your left diaphragm central tendon to become a centered muscle over the left hip, left foot, therefore providing this uniform opposition offered by all the abdominal muscles, not just your IOs and TAs, but all of them to maximize opposition, to maximize carbia, to maximize parasympathetics, to maximize relaxation. All of them are going to be now involved. This technique, along with its emphasis placed on the exhalation phase, with the ground underneath of that left central tendon based reference during left trunk rotation and inhalation when you breathe in, with ongoing left ground based referencing during right trunk rotation, prepares one for sustained normality of carbon dioxide during forward locomotor movement. It is 1/2 of the gait cycle. This technique puts you into a gait cycle with your feet, so forward locomotor movement with your all appendages can at least be maintained with appropriate carbia on your left foot. Otherwise, you're going to go back to inappropriate carbia when you're on your right foot. Inappropriate carbia on your right foot puts you back into acidosis. Acidosis leads to alkalosis, and you're right back into that starvation mode for carbon dioxide. Inhaling without losing left ground anchoring promotes good exchange of carbon dioxide. That's what this webinar was really all about. Carbon dioxide mixture is a physical issue. You have a body that needs a physical alternating set of activities, arm swing, leg swings, to produce sufficient carbon dioxide. If you're laying around and not doing that, you're going to produce insufficient mixture of carbon dioxide with oxygen. Inhaling without losing left ground anchoring promotes good exchange of carbon dioxide. That's what this technique's all about. For oxygen, without losing hemi-diaphragm opposition on that left side or both sides, and thus losing CO2 production on one side or both sides. This is a wonderful anti-anxiety technique. Underline it. It's the best anti-anxiety technique that I have ever put together because of this differentiation between a left central tendon and a right central tendon, as you're about to see. It's a great anti-dizzy, anti-high speed breather, anti-mouth, anti-high blood pressure technique. And when I put anti-high blood pressure technique, it's a great anti-medication technique. Before I show you that one, Jen, I want you to just read for us, if you will, Jen.
Steps 5 through 10.
You got her. Can you do that for me?
Sure. So I'm going to jump to step number 5 here on this technique. Squeeze the ball between your knees and inhale through your nose. Exhale through your mouth and reach forward with both arms. Inhale again, and this time exhale as you reach forward with only your right arm. Inhale and hold this position, attempting to fill your back chest wall with air.
And you want to go slow. So you draw that air in slowly as you maintain that ground position, Jen. Go ahead.
Exhale and reach forward further with your right arm.
For end range, write down for end range. This discussion this evening was about end range. Now we're getting in range with the thorax and the scapula. So as far as forward as you can go, maintain that, hold it, in range, and then what, Jen?
Continue the sequence for one more breath in and out. So inhale, exhale, reach with your right arm. Then maintaining the above position, inhale again as you reach forward with your left arm upon inhalation, attempting to fill your back chest wall with air. Exhale and hold this position.
Read one more.
Inhale and reach further and slightly to the right with your left arm. Reach and rotate as you inhale so that your nose is directly over your right knee. Your body weight will be shifted to the left, and you should feel your left outer hip or buttock engage. Again,
infield left hip, infield right arm. So you can see he's reaching slightly forward with the right arm. Jen, I will stop there. When that right arm is going forward in range, left hip is what? In range. You are in an optimum position to produce carbon dioxide.
And then you flip it around and you reach left arm, but you're still in end range on the left hip.
That's great. You never lose. Carbon dioxide requires left hip floor in range. Gosh, that was fun. That was fast. That was furious. It's a lot of facts. And it's a lot of information. I'm sure it's the first discussion you've ever heard relating carbon dioxide to hemi-diaphragmatic postural positioning. And it's important for you to all remember that this institute believes strongly in this thing called carbon. And otherwise, this alkalosis issue called hyperventilatory activity, or people that are trying to get air in without getting air out first, is probably going to continue as soon as you get done with your PRI exercises, or for that matter, Jen, any activity that doesn't understand kind of what we're doing with the acidosis and alkalosis balance act that we talked about this evening. I want to thank you so much for joining us again this week. I want to thank Jen for producing this and putting this together. You know, I put this together a few minutes before we talk. She slaps it together. She types it up. She puts some slides with it. She says, what is this like? Do you like this? Do you like that? And I go, Absolutely. She calls me back up and says, I don't like it. You mind if I change it? She's the one that's making this easy for you and the masses of people in the future to look at and make reasonable sense out of it. So I want to thank you, Jen, once more. I think we're halfway through this series. Next week, we're going to talk about managing chronic obstruction, not sleep obstruction apnea, but chronic obstruction lung dysfunction, not obstruction sleep apnea. That's a different talk for someone else. We're going to talk about obstruction lung dysfunction. So we sort that out because all sleep apnea is obstruction lung dysfunction. We're going to go over that. I want to make sure you guys understand that's not a talk on COPD. I don't know if we have any more time tonight.
I have one question,
okay.
and we'll just answer this one question. Lucy asked a question just about the position in this technique. It looks like Jason's low back is not on the wall, as in some of the other PRI wall-supported techniques. So is it only the buttock area that should be on the wall?
Good question, Lucy.
Technique?
Good question, Lucy. Thanks again for attending these. It's great to see you. Yeah, buttock, ischial in range. It's not important to keep the back flat on this wall. If you did it, Lucy, it wouldn't hurt a thing. It probably would help, but we're trying to expand and elongate and, distract. So it's a little different. It's a great question.
Trunk rotation with just the buttock on the wall.
Absolutely.
But he's still in that pelvic tilt. So he's still,
Yeah.
keeping that posterior pelvic tilt or that rotation on the wall.
I'd like to ask you all a question before we adjourn tonight. For the people that I can see, do you have a better appreciation, just shake your head yes or no, for carbon dioxide on carbon dioxide's impact on what you do now as a movement specialist? Does carbon dioxide mean something to you after this evening? Hopefully, yes, because that's really what this is all about. We're not here to talk more about exercises or techniques. We're here to talk about physiology of lungs, and ventilation and perfusion has carbon dioxide written all over it. So I just want to make sure, go back, relook at the notes. I went through some of them fairly fast to get it done in 45 minutes to an hour. I'm always pushed for that time, but you have some pretty good handouts in front of you, so take a look at it again. Are there any other questions?
Nope, that's all for tonight.
Thank you,
Thanks
everybody.
again for joining us. We'll try to address at least a couple questions each week because we really appreciate you guys tuning in live with us each week. And so I want that to be kind of a benefit to those of you who are able to tune in live with us each week. So thanks again for joining us, and we hope to see you again next week.
Thanks, everybody.